Okay, so the final talk during this symposium will be actually on Magnus' most favorite topic, which is epigenetic DNA alterations and their potential for cancer diagnostics and prevention. And for this topic, we have an expert coming here to Heidelberg from Amsterdam. This is Professor Renske Steenbergen, who is Professor of Experimental Pathology at the Department of Pathology, Amsterdam University Medical Center, Cancer Center Amsterdam, the Netherlands. She has a 30-year track record in translational research on HPV-induced carcinogenesis, and through the comprehensive molecular analysis of in vitro cell culture models and clinical specimens, she developed DNA methylation and microRNA markers for cervical and anal cancer screening and risk stratification of HPV-induced precancerous disease. In recent years, she extended her research further to early cancer detection in at-home collected samples like urine. So welcome on the stage, and we're looking forward to your talk. Thank you so much for the nice introduction and also for this very kind invitation to be here at this special event and celebrating your retirement, as I understood. I'll talk about DNA methylation markers, and although I was not like your student, I was actually a student of IS, who was also in the room. But we also had very inspiring meetings at HPV meetings on methylation markers can be measured in urine, as we are doing now, but also, and that's your endeavor, can be exploited knowledge to develop therapies. And I think it's really exciting that together with Elena, you actually managed to develop a topical demethylating agents that is now also in clinical trials. So I think that also shows your perseverance to really get to something that we can use in the future. And so I'll further dive into your favorite subject and also my favorite subject, so epigenetics and DNA methylation, and this talk how can we exploit it for diagnostics. So talk about the promise of DNA methylation methods for the detection and risk stratification of HPV-induced neoplasia. And this is my conflict of interest. So we have seen sort of the slide already by Nico before, but I thought I should introduce it a little bit to you to show you some background on the biology of HPV-induced cancers, which I think know from also this morning starts with the HPV infection, which can cause like low-grade lesions, which we call low-grade squamous epithelial neoplasia or lesions, which are associated with the productive infection. But when the virus persists, high-grade lesions can develop, which over a really long period of time can develop into cancer. And this all relates, as we heard also this morning, to deregulation of E6 and E7 viral oncogenes. And it's the deregulation of E7, which also is associated with P16 upregulation. So this is what we see in those high-grade recurrent lesions. It's in the end to really develop into cancer following deregulation in 67, the upregulation of P16. Also, molecular aberrations in the host cell genome need to occur. So we need additional oncogenes to be activated, additional tumor suppressor genes to be inactivated. So it's a long-term process because it's HPV, it's the deregulations, the oncogenes, and then it's an accumulation of many more aberrations that actually make those precursor lesions drive to cancer. And one of those events which we are studying is DNA methylation. So in the past years, we did quite some studies to find and to exploit which DNA methylation events are now actually occurring in the real process of HPV-induced carcinogenesis. So what methylation alterations do we see in the host cell genome? And we performed both targeted and genome-wide discovery methodologies to find what we call methylation biomarkers. There are methylation events that are actually characteristic for the carcinogenic process, so for progression to cancer. So I already introduced DNA methylation epigenetics, but what is actually DNA methylation? So DNA methylation is the addition of a methyl group to the cytosine in our DNA, and it's always a cytosine when it's upstream of a uranine. And the addition of such a methyl group to the cytosine can be induced by activation of the enzyme DNA methyltransferases, which, for example, can be activated by HPV viruses, but also by like the HIV virus. And this is a process that is occurring in normal development, but it's also a process that's occurred in many cancer cells. And what's the effect? So here we see in a normal, this is a gene promoter. So this is where like gene transcription factors can bind to activate gene transcription. And here you see the lollipops, those are cytosines next to a uranine. And often in the promoter region of a gene, we see like really stretches of CPDs, which we call CPD ions. And when those cytosines are not methylated, the gene can be transcribed. But what we often see in a cancer cell, we see hypermethylation, extra CPD ions. So meaning that a lot of Cs in such a promoter region are methylated, as of which transcription factors cannot bind anymore, and the gene is inactivated. And it's this mechanism of DNA methylation of promoter genes, of promoters of genes, and especially tumor suppressor genes, which is really one of the frequent events of inactivating tumor suppressor genes. So we see this very often. Using our genome-wide screens, we identified genes that are specifically methylated in HPV-induced neoplasia. Oh, what happens? I think I pressed the wrong button. It's not yet. There's again. So we are really studying DNA methylation because it's biologically relevant in cancer development, and we can also measure it quite easily. It's not AI; it's still like simple molecular biology. Using quantitative methylation-specific PCR, which is a highly sensitive method, so we can detect methylation of certain genes in the background of many normal genes and normal DNA, and it's also highly reproducible. And for this method, I'm just to see that I have pressed the right button. You have to isolate DNA, and then we need to modify the DNA using like a chemical or an enzyme. And I don't think you see the pointer. For here we have an unmethylated cytosine, and then it's treated by a chemical bisulfite. It will turn into uracil, and when it's methylated, it's protected from conversion, and we make a cytosine. And using PCR-specific primers, we can make a distinction between methylated DNA, unmethylated DNA. And also, we already invested a lot in developing tests in which we can detect multiple markers, multiple genes in one single multiplex assay, which saves cost and time and material, and also makes it more reproducible. So one of the tests that has been studied the most is the chiral methylation test we developed in our lab, which measures methylation of two genes, the FEM19 A14 and the MIR124 gene, which were identified also by genome-wide studies. And in this study, is this one example, we studied over 500 cervical cancers in a worldwide series, so they came from all different continents. And we found that nearly all of those cervical cancers were positive for those two methylation markers, and which was independent of the different histotypes. So showing that methylation, at least of those genes, and we know also for other genes, is really associated with cervical cancer. And one of the other studies, big studies, which was performed using those methylation markers with this methylation test, was a European study funded by the Horizon 2020 program called Screen, in which over 2,000 cervical scrapes, HPV cervical scrapes from screening cohorts in Europe were tested. And also in this validation study, it was found that 95% of the cancers were positive. 77% of the precursor of the SIN3 were positive, and about 50% of the SIN2 lesions were positive at almost 80% specificity, showing that also in a screening population, methylation testing using those markers has a good clinical performance for the detection of precursor lesions in HPV positive women. But as I showed you in the previous slide, we did not detect all the precursor lesions. We detected all the cancers, and we detected the subset of the precursor lesions. And we also know from out of the clinic that the precursor lesions, only a subset actually progresses to cancer. So in case of the anal canal, it's only like 10%. If you think about the cervix, it's like 30% of those precursor lesions that actually will progress to cancer. So based on this observation, the DNA methylation is associated with cancer development. We questioned ourselves, can we use those methylation events and those methylation markers for cancer risk stratification of those precursor lesions? So we have this following concept, which we already put out a while ago, that if you look at the high-grade precursor lesions, we can make a distinction between low-risk lesions, which actually have a low risk of progressing to cancer, and that we have what we call advanced lesions, which have a higher risk of progressing to cancer. And our hypothesis was that DNA methylation may give an indication on the state of disease of those precursor lesions, because there are quite some pathologists in the room, but pathologists, when you're looking under the microscope to those high-cell lesions, no distinction can be made between it being a low-risk lesion or being an advanced lesion. They are all also P16 positive. And we think that based on the molecular events that drive cryogenesis, we can make such a distinction. And to first assess this assumption, we took advantage of some SIN3 lesions, SIN2 lesions, from also a large population-based screening study, in which we knew the duration of the HPV infection. So we had SIN lesions, which we called early lesions of women that just acquired the HPV infection like a year or 2 years before. And we had lesions of women from whom we didn't know that they already were carrying HPV for more than 5 years. And what we found is when in those lesions that had a longer HPV infection, so potentially they were further down in the process, we found a significantly higher methylation levels of specific genes compared to the early genes. And actually the methylation levels we found in those lesions were very similar to as what we found in cancers. And this information may be important if you think about the clinical management of those precursor lesions, because we can either think about a conservative treatment, so you could not treat the lesions because they have a low cancer risk, and you would do like close surveillance with cytometry or HPV testing and colposcopy, or you can choose for a surgical treatment. And why such a distinction can be made is based on the fact, which I already alluded to before, is that those precursor lesions, many of precursor lesions actually do not progress, and there are actually many that do regress. So of the SIN2 lesions, about 40 to 50% of the SIN2 lesions are known to regress, so they will never progress to cancer. And also about 30% of the SIN3 lesions are still regressing, while progressing to cancer is low in cases of SIN2 lesions, and it's up to 30% in cases of SIN3 lesions. So if you would treat all SIN2-3 lesions, knowing that a lot of them actually will regress by themselves, would also lead to overtreatment, which is mainly can be a problem of, for example, pregnant women or women that still would like to get pregnant post treatments of those lesions can have some adverse effects in pregnancy. So to see if you can use those methylation markers maybe to predict whether lesions would regress or progress, we performed the Conserve study, which is a prospective study to evaluate the performance of the methylation markers in the prediction of clinical regression of untreated SIN2-3 lesions. And this is what the study looked like. There were over 100 patients with SIN2-3 lesions included. Those are all still smaller lesions, also for epiphal approval. And those women were not treated, but they were followed up closely at 6, 12, 18, and 24 months using a self-sample, a cervical straight, and colposcopy. And women were only treated when the lesion was growing, becoming more than 50%, or when progression was seen. And the study endpoint was the absence of the lesions, or clearance of the lesions, or clearing, being HPV negative and having normal cytology. So the outcome of this study was regression. And what was found, this is shown here, we studied both methylation in clinician-collected cervical straight as well as in self-collected vagina samples. So the women collected those samples at home. And what is shown here is the cumulative regression. And the blue line are the methylation-negative straights, or in the dotted line, the methylation-negative self-samples. And we saw more regression in the methylation-negative samples than in the methylation-positive sample. So indicating, that methylation negativity can be used as a predictor of regression and maybe an indication for not performing immediate treatment for the patients. So as a confirmation also of this study, it was another study performed in Finland where they also included 160 untreated SIN2 lesions with 2-year follow-up. They measured methylation of another methylation panel, which is called the S5 classifier. And what they showed was that in SIN2 lesions that were progressing, there was higher methylation than in SIN2 lesions that were regressing or in SIN2 lesions that were persistent. This is also an independent study actually having very similar findings. And also more recently, a study was published on the Fintech methylation test developed by Matthias Buur, who was also there in the audience. And they actually also had very similar findings, especially in SIN3 lesions, where they found more regression indicating brain in the methylation-negative cases compared to the methylation-positive cases. So there are 3 independent studies showing that methylation detection in cervical straights can give an indication of lesion regression or progression. So this is for the cervix. But we did very similar studies for anal cancer, and this is our anal cancer team from a nice group picture. And anal cancer is less prevalent than cervical cancer, but it's still quite prevalent in certain populations, which are MSM, men having sex with men living with HIV. And this population has a 85% higher risk of anal cancer than the general population. And in this population, we also see a lot of HSIL. Almost 1/3 of this population has HSIL, so cancer precursor lesions. So for this reason, such this at-risk population, as well as some other risk populations like HSV-positive patients in general, or women with a history of throat cancer, are advised now to be screened for anal cancer. It means screening and treatment of the precursor lesions to prevent anal cancer. And those guidelines actually just came out last year. So also in the Netherlands, the screening program for HIV-positive MSM or MSM living with HIV that are actually now screened by high-resolution endoscopy to look for precursor lesions, and if precursor lesions are found, those are treated. But we also know that, and especially for the anal high-grade precursor lesions, progressive cancer is really, really low, and it's about 0.4% progression risk per year. So currently, most of those patients are treated. Treatment is quite cumbersome and complex, and many of those patients are actually over-treated because they don't have a high cancer risk. And especially for treatment of anal lesions, it also suffers from a high recurrence rate, up to like 50%. So we ask ourselves also, can we use the methylation mark also for cancerous stratification of those anal precursor lesions, and can we use them to determine who actually needs treatment and who can be kept under close surveillance? So we first did an explorative study in which we analyzed the 9 methylation markers on almost 150 anal biopsies, and we identified 6 markers that could make a good distinction between controls and low-grade lesions and high-grade lesions. Subsequently, we formed a validation study in which we identified 6 markers. We validated those 6 markers on another series of almost 350 anal biopsies. And we found an optimal marker which had a good performance for the detection of both precursor lesions and anal cancer. And this is actually what the picture looked like, what we got in the lab. It's not an AI picture, it's still just made in Excel. But we plotted here the methylation levels of the 6 markers that we tested per patient. So this is one little row is one patient, and when it's green, it means there's low methylation or no methylation, and when it's red, it means there's high methylation. And what we saw is actually when we looked at the anal cancers, actually almost all anal cancers were red, meaning that they had high methylation of those 6 markers that we tested. But if you look at the high-grade precursor lesions and then the AN3 lesions, we saw that part of them was staining red and part of them was still staining green. And we saw the same in the AN2 lesions. And if we look at our panel and we classified them as positive and negative, we found that part of the precursor was positive and part of the precursor was negative. So we questioned ourselves, is methylation positivity in those precursors associated with progression to cancer? Because that's our hypothesis, and we had to test that hypothesis. And we were very lucky to collect some samples, retrospective samples, from patients that actually had anal cancer, and there were still biopsies available in the pathology labs that were taken before cancer development. And some of those biopsies actually also came from our jury. So, for example, this is one patient, age 51, which is HIV positive, and we measured methylation in 3 biopsies of the cancer, and they were all very highly methylated. They are all very red. And then we looked at the precursor lesions taken before cancer diagnosis up to 28 months before. And all of those high cells were already very, very highly methylated. And to correct for those precursor lesions being actually potential precursors of the cancer, we made sure that they were from the same location and also contained the same HPV type as the cancer. And we have a total of 10 of those cases. They were actually coming from across of Europe. And we found in all instances that the HCL that were preceding cancer were methylation positive. So from this we went on with our optimal marker panel to also develop that into a multiplex test. And this is also where valorization comes into place and translational research. So we did this together with our company Selfstream. So we developed a test containing the genes ARCL1 and ZNF5A2, which are the optimal markers for the anal lesions. And we showed in this training validation that it was very similar to what we did before in our research setting. And we found that all cancers were positive when we looked at the specificity of 70 and 80%, which is shown here. And we also found that about 50% of the high-grade lesions were methylation positive. So we questioned ourselves again, does methylation positivity of this methylation test give an indication of the clinical behavior of those precursor lesions? And this is still ongoing data, but we have a small set of precursor lesions of which we already know that they were regressing. And we found that in those, their methylation levels were very low. And we had a series of progressive HCl, which showed high methylation. And this is like the cross-sectional series of HCl, which show a very methylation levels. And also the cancers were methylation positive. So the idea is that we can use those methylation markers to stratify those precursor lesions into low risk and advanced AL precursor lesions. It's for the methylation negative ones, we can have a wait and see policy. And for the methylation positive ones, that may be an indication for treatment. And to further validate this, we are performing a clinical prospective study, which is called the Marine trial, DNA methylation analysis to predict regression of high-grade anal neoplasia. So it's similar to the study we performed on the shieldful lesions. To determine if a negative test can predict regression. We are now halfway the study. We did some, I think we have quite some nice results coming out, but this will at least take another 2 years before we are fully done with our follow-up periods.